Making the pivot from volume to value is not going to be easy, as we know. And since we have the first College of Population Health in the country, I like to think we've been among the leading voices in how to go about doing this pivot. I've made an analogy that it's like turning a battleship around inside the Panama Canal. You know, sounds pretty hard to do. And believe me, I get it, and I feel the pain of our clinical, procedurally based colleagues for sure. But we have some new tools, and those new tools are principally the tools in the Affordable Care Act. Pay-for-performance programs that say, okay, primary care doctors and cardiologists, if you control blood pressure in this particular population, we're going to give you a modest bonus. If you lower LDL cholesterol, we're going to give you a modest bonus. If you keep people out of the hospital. So part one of the economic incentives that drive a change in clinical behavior are these pay-for-performance programs. Let's talk about a couple of other incentives. Also under the Affordable Care Act, something called bundled payment. I'm sure our viewers are concerned about this. That's not just the old gatekeeper model. That's primary care doctors like me working with cardiologists and getting one lump sum for our work together. Well, this is going to mean that I'm pretty interested in which cardiologist, for example, will be in the network with me, who's going to do a good job, who's going to return the patient to me, who's going to be a good communicator, who gets good outcomes, who doesn't put 87-year-olds on simvastatin. So bundled payment is another approach, change the economic incentive to change behavior. We then have, after bundle payment, things like patient-centered medical homes. And there are cardiology-specific, as an example, patient-centered medical homes. That's all about care coordination, closure of the feedback loop with good data, measurement, information systems. So this is going to mean training a different type of doctor for the future who will be comfortable in a patient-centered medical home. And then finally, the other end of the spectrum, we have accountable care organizations, which are really organizations that are created under the Affordable Care Act that are a mechanism for bearing global risk. So let's review. We've got a lot of new tools. Tools from pay for performance, bundled payment, patient-centered medical homes, accountable care organizations. We believe in the College of Population Health that these tools, these aspects of reform, are really going to influence behavior. And I think we have some pretty good early research evidence that that's exactly what's happening. Pretty clearly, population health has gotten a real tailwind from the Affordable Care Act. My own view would be, yes, without that tailwind, we probably wouldn't have created a brand new college. However, we were smart and lucky too that we actually opened the doors to our college on September 9, 2009, 9909, over a year prior to the launch of the Affordable Care Act. So I think reform certainly was a stimulus. We knew that major changes were coming. Here's the background music. The United States spends 17% of its GDP on healthcare. No other country in the free world even comes close to that. So then you have to ask, well, what do we get for our investment? Well, we're number 17 in the world, so it's easy to remember. 17% of the GDP gets us number 17 in the world, according to the best evidence from the National Academy of Medicine, January 2013, in their report called Shorter Lives, Poorer Health. So I'm sure, like our viewers, I'm a pretty competitive guy. I want to see our great country in the top 10. Not number 17. So we've got a long way to go. I think the tools of the Affordable Care Act will help. I think the transition from volume to value is going to take some time. And we have some new tools coming our way in the next 2 or 3 years. But I think for this section, it's important to remember, Medicare plans on connecting 50 cents of every dollar spent to a measurable outcome by 2018. In a year and a half from now, we're going to be faced with a whole new payment system, 50 cents of every dollar from Medicare connected to an outcome measure. That's revolutionary, not evolutionary.